Let's go ahead and get started this morning. It's my pleasure to introduce Dr. Meeghan Lautner, who is our guest speaker this morning. She's one of our chief residents in our program, and she's going to be talking about the management of advanced breast cancer. Dr. Lautner is from Michigan. I'll have to brush my teeth again. Went to Saginaw Valley for undergraduate, and then went to Wayne State for medical school, and then has been here. When she completes her residency, she has a fellowship in breast surgery at MD Anderson. Please help me welcome Dr. Lautner.
Thank you, Dr. Staranek. Yes, there's quite a rivalry between Michigan and Ohio, for those who don't know, so I try not to hold it against him.
Michigan.
So, as he mentioned, I'm going to talk about the management of advanced breast cancer. I have a couple goals. First is to not repeat Dr. Amir's presentation from a couple weeks ago on breast cancer, and the second is to discuss some of the current issues that are occurring in advanced breast cancer today. So, breast cancer is the most common cancer affecting women worldwide. Approximately 1 in 8 women will be diagnosed in their lifetime. It is the second leading cause of cancer death in women, second only to breast cancer, or to lung cancer, Each year, approximately 1.05 million new cases and 373,000 deaths worldwide are due to breast cancer. And here in the U.S., we have the highest incidence, occurring in 99.4 women for every 100,000. We have 40,000 deaths each year due to breast cancer, and every day there's an increasing number of women living with breast cancer. This is due in part to advanced screening and treatment modalities that allow us to diagnose breast cancer sooner and treat it more effectively. But part of this increase is undoubtedly due to awareness, which is everywhere. In the social media, professional sports, in October, the NFL and the Major League Baseball corporations both show their endorsement quite readily. And politics even plays a role. You can see the White House there lit up in pink, and other catchy slogans such as Save the Tatas. Hollywood has also contributed to breast cancer publicity. Several celebrities expressed their support, either male or female. You can see Liam Neeson at the top there with his pink purse, which I don't think he had at the Oscars last night. And then there's the onslaught of women who have been very public about their diagnosis and treatment. So we'll have a little bit of celebrity breast cancer trivia throughout the presentation. So let's get started. Anybody know who this is? Sheryl Crow, right? She was diagnosed at age 44. Next. No. No, she's not a country singer. Who knows? Melissa Etheridge, yes. 43 years old at diagnosis. Next one's tough. I didn't know. I know in the name. Oh, yeah, okay, fine, you know. Sorry, you're sure. She was 36 when she was diagnosed. I don't think she's Indian. I don't know. Anyway. So the Smith surgical papyrus is the earliest known document to refer to breast cancer. A papyrus is basically a medical text from ancient Egypt. Most of these spoke of magic. However, the Smith surgical papyrus is actually based on medical knowledge. Edwin Smith was from Connecticut, and he was an Egyptologist that purchased the papyrus in the 1800s. It was eventually translated with the help of medical professionals and found to describe breast cancer in a man, and encompassed most of the clinical features we see today. The author concluded at the end of the document, there is no treatment. Next, in the 1st century, Celsus of Rome was the first to comment on the value of surgery in early breast cancer. He stated, "None of these may be removed but the early cancer. The rest are irritated by every method of cure." In the 2nd century, Galen made the observation that breast cancer resembles a crab. He noted that in breast cancer, the veins extending out from the unnatural growth take the shape of crab's legs. He also spoke of pursuing negative margins by taking the tumor in a circle where it borders normal tissue. For the next almost 20 centuries, surgeons continued their attempt to intervene on breast cancer. Most considered it to be futile. Around the 18th century, the theory took hold that the local disease spread by the way of lymph nodes, and then after another century, more in England began to emphasize the complete resection of the breast and other palpable lymph nodes. This led to the birth of the well-known Halsted radical mastectomy in 1894. This includes removal of level 1 through 3 nodes, which I'll go over in a little bit, pectoralis major, and long thoracic and thoracodorsal neurovascular bundles. The radical mastectomy persisted as a surgical treatment for breast cancer until 1943. In the 1940s, it became apparent that women with evidence of advanced disease, such as edema or ulceration of the skin, chest wall fixation, fixed or large axillary nodes, had very poor survival and were beyond cure even by radical mastectomy. Patey and Dyson in London began to advocate the modified radical mastectomy, though they also observed that until an effective general agent is developed, a high proportion of these cases are doomed to die. In their modified radical mastectomy, they included removal of the pec minor in order to dissect the level 2 nodes, and this was eventually modified further to the procedure we know today by Madden in the 1970s. Subsequent studies, namely the NSABP 04, have shown that the radical mastectomy does not increase survival and is in fact quite morbid. Okay, here we go. Here's some more. This one's kind of easy, I thought. Yeah, Christina Applegate. She is 36 at diagnosis. Interestingly, she's a BRCA1. She has BRCA1, so does her mother, who had recurrent breast cancer. So she had a bilateral mastectomy with reconstruction. Cynthia Nixon, nice, for sure. You're all over this. She was 40 at diagnosis. And this one's hard, too, because she doesn't look like she did in the show. It's Edie Falco from The Sopranos. She was 40 when she was diagnosed. So they don't have HBO in India. To quickly review the anatomy of the breast, it is composed of 15 to 20 lobes, which are then composed of several lobules. Cooper's ligaments are the connective tissue that provide the structural support. In between here, there's an axillary talus bench which extends across the anterior axillary fold, and the upper outer quadrant of the breast contains the greatest volume of breast tissue than do the other quadrants. Each lobe of the breast ends in a orifice ends in a major duct which opens through a constricted orifice in the nipple. And the principal blood supply of the breast is from the perforating branches of the internal mammary artery, lateral branches of the posterior intercostal arteries, and also branches from the axillary artery. The venous drainage, along with the lymphatic drainage, as we all know, is towards the axilla here. The treatment of the axilla is often an important component of advanced breast cancer. It consists of the lymphatic drainage of the breast separated into 3 levels by the pectoralis minor, as you can see here. Level 1 is lateral to the pec minor, level 2 is beneath, and level 3 is medial. The anterior border of the axilla consists of the pectoralis major and minor. The posterior border is the subscapularis. The lateral border, depending on if you're reading a surgical text, is either the latissimus dorsi or the bicipital groove, and the medial border is the serratus anterior. The axillary vein is the superior border, seen here and here. And it gives branches that contribute to the neurovascular bundles whose identification is critical during axillary dissection so that we may avoid these structures. These include the thoracodorsal nerve going to the latissimus dorsi and the long thoracic going to the serratus anterior. When one thinks about breast cancer or hears about it in the media, there are 2 classifications that become quite prominent: early stage breast cancer and advanced stage breast cancer. As we all know, those terms are an understatement of what goes into determining the stage of breast cancer. This is a simplified version of the AJCC TNM staging system, which we all see today. In order to understand the distinction of advanced stage breast cancer, I'm going to spend some time going over what all these numbers and letters mean. So we begin with the T, which stands for tumor, of course, and it basically ranges from 0 to 4, 0 being no evidence of primary tumor. The IS indicates your in situ disease, and as the numbers increase, so do the size of the tumor, as you can see here. From 2 centimeters or less in the T1 up until 5 centimeters or greater, and then T4, of course, includes your chest wall or skin invasion. Next, we move on to the N, which stands for nodes. And there are 2 different distinctions when you talk about nodes. There's first is the clinical stage, so this is what you see on exam. So you have N0 ranging from N0 to N3, with N0 being no regional, no metastasis. X means they cannot be assessed, perhaps they've been removed before. And up to N3, which is your level 1 or 2, so those that are lateral underneath the pectoralis minor, and internal mammary nodes, or your level 3 nodes, so those that are medial, or ipsilateral supraclavicular nodes. When you take it to the pathologic stage, these are the results that the pathologists get when they analyze a specimen that was removed at the time of surgery, and these also range from N0 to N3. So you can see as you have an increasing number of lymph nodes that are positive for malignancy, you get a greater N distinction. So therefore, when we talk about advanced breast cancer, we can basically isolate this group of patients. So those that have a T3 tumor and above, as well as metastatic disease. So in summary, advanced breast cancer contains stage 3 or stage 4 disease, T4 tumors, so the large ones that are affixed to the chest wall or the skin, N2 or higher. Inflammatory breast cancer often falls into this category. I'll discuss why in a little bit. And then, of course, anyone that has metastatic disease is automatically considered advanced stage. Okay. There's this one. Who knows what this is? Yeah, Suzanne Summers. She was diagnosed at age 54. Next. This one I didn't know. I didn't know she had breast cancer. It is not Papadopoulos, oddly enough, but her name is Mara Turney. So she was Abby on ER. Yes, she was diagnosed at age 42. And this next one, I don't know if anyone will know. Jacqueline Smith. So she's a designer, was very popular back in the 70s and 80s. She was diagnosed at age 56. So when we talk about how we work up breast cancer, pretty much everybody nowadays refers to the NCCN Guidelines. This is a very easy thing to use. You can find it easily online, and most of us have apps on our phone, which will tell you staging, but it also will tell you how to work up a patient with breast cancer. So when we talk about advanced breast cancer, we're talking about stage 3A. And what they recommend is do a complete history and physical, obviously, and your general laboratory values, including LFTs. You need to get a contralateral mammogram if you haven't got one already. Your hormone receptor status, which can be done on the biopsy, and you need to have that in order to accurately stage and come up with treatment decisions. You need to consider genetic counseling and fertility counseling if the patient is high risk and of childbearing age. Breast MRI is a very controversial topic nowadays, and whether or not it needs to be part of the workup. You need to get a CAT scan of the chest, abdomen, pelvis, a bone scan, and a PET scan. When you move on to stage 4 disease, which means metastatic disease, you can do the same workup and then consider some brain imaging if the patient has CNS symptoms. So once you complete the workup, then the patient's first question is usually, what's next? What are we going to do to take care of this? In the setting of advanced breast cancer, the answer nowadays should be neoadjuvant chemotherapy. Despite the fact that the patient wants the cancer removed and we want to remove it, I'm going to provide some evidence as to why it may be better to give the neoadjuvant chemotherapy first. So the current recommendations for giving neoadjuvant chemotherapy in breast cancer include locally advanced breast cancers that we just discussed, those with internal mammary or supraclavicular node involvement, chest wall or skin involvement, non-fixed matted nodes, and limited infraclavicular nodes, and also, perhaps most importantly, those with a large tumor who desire to have breast conservation therapy. So one of the disadvantages of neoadjuvant chemotherapy, some feel that it can delay local and regional treatment. So you have a risk of tumor progression while the patient is undergoing chemo, and of course the patient's anxiety level is quite high because the tumor is still there. You can also lose your pathologic staging by over or under treating. And the NSABP was a randomized controlled trial that occurred in the late 1980s, early 1990s. And what it was done to compare pre- and post-operative chemotherapy in patients with operable breast cancer. The primary aim was to determine if it resulted in improved survival and disease-free survival, which, as you can see here in these figures, it did not. It's exactly the same. So if neoadjuvant chemotherapy does not improve survival, what does it do? Well, most importantly, for some patients, it may downsize their tumor from inoperable to operable. It may allow for breast conservation therapy versus mastectomy. So if a woman has a large tumor relative to her breast size, she may have to go undergo a mastectomy. But if the tumor shrinks when you give her chemotherapy, she may qualify for a lumpectomy and radiation. Despite not showing a survival advantage with neoadjuvant chemotherapy, what the B18 trial did show was a statistically significant association between clinical and pathologic tumor response to preoperative chemotherapy and long-term outcome. This is one of the advantages of neoadjuvant chemotherapy in that it allows us to determine who is responding to therapy. This response, or perhaps a lack thereof, may function as a prognostic factor and eventually lead to the determination of biomarkers of response. So if the patient has already requested a mastectomy regardless of tumor size, should neoadjuvant chemotherapy still be given? Some argue yes, purely to determine if the patient is a responder, meaning are they going to respond to the chemotherapy that's given, not only with the size of the primary tumor, but also with the response of the lymph nodes. Mamunas recently released an article which showed some combined data from B18 and B27. B27 was another trial looking at neoadjuvant chemotherapy, just a different regimen of drugs. And in the combined data set, they focused on local regional recurrence rates. They found that by combining the data, in addition to age and clinical tumor characteristics, pathologic response of the breast and axillary lymph nodes have a major impact on the rates and patterns of local regional recurrence. They also found that the risk of recurrence increases to greater than 10% for those patients with 1 to 3 positive lymph nodes after neoadjuvant chemotherapy. So you give the neoadjuvant chemotherapy, they go to surgery, they still have positive nodes. The recurrence rate is very high. What the authors of that study are arguing, though, is that this may be a tool to determine the optimal use of radiation. So in other words, if radiation may be able to be avoided if you have a complete pathologic response because your recurrence risk is very low. That said, evaluating the axillary lymph nodes in the setting of neoadjuvant chemotherapy has become a very controversial topic in breast cancer. In fact, some of the preliminary landmark data was presented here in San Antonio at the symposium just a few months ago, and it centers around the timing of sentinel lymph node biopsy in relation to neoadjuvant chemotherapy. So while B18 did not show an improvement in survival with neoadjuvant chemotherapy, it did show a significant response of the primary tumor in the axilla. 73% of patients had a complete clinical response, meaning they had a palpable tumor. After neoadjuvant chemotherapy, they had no palpable tumor. 36% had a complete pathologic response and negative nodes after dissection. So they had a tumor, had positive nodes, got a neoadjuvant chemotherapy, then went to surgery. Their pathologic specimens were negative. Therefore, the question is being asked if neoadjuvant chemotherapy can prevent axillary lymph node dissection, meaning if you don't evaluate the axillary lymph nodes until after neoadjuvant chemotherapy, will you have less positive nodes and therefore less axillary dissections? Some people feel, however, that neoadjuvant chemotherapy causes obstruction of the lymphatic pathways, making your evaluation of the axilla unreliable. The response of the lymph nodes to chemotherapy may be non-uniform, and again, the reliability is limited. So when we talk about sentinel lymph node biopsy before neoadjuvant chemotherapy, what does the data show so far? So we all know the accuracy of sentinel lymph node biopsy when using both blue dye of some sort and radiocolloid is almost 100%. So the studies supporting performing a sentinel lymph node biopsy before neoadjuvant chemotherapy basically say, why mess with the good thing? We know it's reliable, so do the sentinel lymph node first, then give neoadjuvant chemotherapy. It avoids the confounding effects of the neoadjuvant therapy, obstructing or interfering with lymphatics, and if the sentinel lymph node is reliably negative, you can avoid axillary dissection after neoadjuvant chemotherapy. This is exactly what Dr. Sable at the University of Michigan argued. He looked at 25 clinically node-negative patients. He identified 100% of their sentinel lymph nodes. Then he gave neoadjuvant chemotherapy. 13 of the 25 were positive, and 12 underwent axillary lymph node dissection after neoadjuvant chemotherapy. 5 had no residual disease. He argues that the 12 patients that had a negative sentinel lymph node and reliably avoided axillary lymph node dissection were able to do so because there's no convincing evidence that patients with a negative sentinel lymph node biopsy after neoadjuvant chemotherapy can be spared the axillary lymph node dissection. Similarly, Olila in 2005 looked at their patients, and they had 21 of them. They found 21 nodes prior to neoadjuvant chemotherapy. 9 had positive nodes and underwent axillary lymph node dissection after they received chemo. And they followed these patients for 36 months, and they had absolutely no recurrences. So they argued that the sentinel lymph node before is reliable and also can help predict recurrence rates. In summary, the advantages of sentinel lymph node biopsy prior to neoadjuvant chemotherapy include a more accurate staging of the axilla, a higher sentinel lymph node identification rate, a lower false negative rate, and the ability to determine the response to treatment. The disadvantages, however, include a potential delay in treatment due to OR scheduling, wound healing, etc. The patient has to undergo an additional operation, so sentinel lymph node biopsy before, and then, sentinel lymph node biopsy before, and then they proceed with definitive treatment after neoadjuvant chemotherapy. And the increase in doing axillary lymph node dissections because the positive nodes could potentially be downstaged by neoadjuvant chemotherapy. And loss of evidence of nodal response to neoadjuvant chemotherapy in those nodes that were previously removed with the sentinel lymph node biopsy prior to initiation of treatment. In order to investigate if performing a sentinel lymph node biopsy after neoadjuvant is accurate, all studies require patients to undergo an axillary lymph node dissection regardless of sentinel lymph node biopsy status. A meta-analysis done by Zing in 2006 found an accuracy rate of 94% in sentinel lymph node biopsies performed after neoadjuvant. Their identification rate was only 90%, and they had a false negative rate of 12. Furthermore, a subgroup of the NSABP B27, so again, this was a study that looked at neoadjuvant chemotherapy and its effects on survival. And they analyzed a subgroup of these patients where they had sentinel lymph node biopsy performed after neoadjuvant chemotherapy. And they found a similar false negative rate at 11. Their identification rate was even lower at 85. And they, of course, told us what we already know, which is that the mapping is more successful with blue dye and radiocolloid. Most recently, Dr. Hunt and MD Anderson looked at their experience, and they, of course, surprisingly found an identification rate much higher than everybody else at 97%. Their false negative rate was even lower at 6, and all their patients were clinically node negative at presentation, and they concluded that they had higher identification rates with surgeon experience. So to summarize, the advantages for performing a sentinel lymph node biopsy after giving neoadjuvant chemotherapy includes requiring the patient to undergo only one operation, a decreased incidence in axillary lymph node dissection secondary to downstaging of the lymph nodes, and the prognostic value of the post-neoadjuvant chemotherapy axilla, so you can tell how well a patient responded. The disadvantages, however, are obviously much lower identification rates, unless you're at MD Anderson, and higher false negative rates, which are still higher than those we see in a essentially non-treated axilla. And the unknown effect of the downstage node. So what does it mean if the patient had positive nodes, got neoadjuvant, and then now they're negative? Both sides of the argument are compelling, and unfortunately right now there is no reliable randomized control study to convince us one way or the other. However, as I alluded to earlier, some of the preliminary data was presented here at the Breast Cancer Symposium of such a randomized controlled trial. It's called the Z1071 trial. And what it was designed to do was to evaluate sentinel lymph node biopsy after neoadjuvant chemotherapy in node-positive women. All sentinel lymph nodes were followed again by an axillary lymph node dissection. All used the dual tracer technique, so blue dye and radiocolloid. Their identification rate was 92.5%, and their accuracy rate only 84%. False negative rate was still quite high at 12.8%, but they did say that in 40% of the patients that had no N1 or N2 disease, had their disease eradicated by neoadjuvant chemotherapy. They haven't released all the data and the paper's not out yet, so we anxiously await the results so that perhaps a guideline may be developed as to which is the best way to investigate the axilla. They did state that they had lower false negative rates when they took out at least 3 sentinel lymph nodes, but as we know, it's still not comparable to those sentinel lymph node biopsies done before neoadjuvant chemotherapy. So neoadjuvant chemotherapy is becoming more and more popular, so the next step is to figure out if it has as much of a downsizing effect in the axilla as it potentially can have in the primary tumor. So we know it lets people go to breast conservation therapy, but can it really give us a good idea of what's going on in the axilla? Okay. More people. If anybody watched the Oscars. Juliana, I don't know how you say her last name, but yes. So she was diagnosed at age 35, interestingly enough, when she was undergoing, I think it was her second in vitro attempt to have a baby. So. Yes, Wanda Sykes. She was diagnosed at age 47. And even you should know who this is, Dr. Cernik. Olivia Newton-John, yes. She was diagnosed at age 44. She looks much different nowadays. I had to go back and find an older picture. So one of the other recent things that's coming about is neoadjuvant endocrine therapy. So we all know about tamoxifen and aromatase inhibitors giving it in the adjuvant setting, but in Europe they're starting to do a little bit of the neoadjuvant setting. So they argue that it's less toxic and it's better tolerated than neoadjuvant chemotherapy. They have a higher rate of complete pathologic response. They also say it may downsize the tumors so patients can undergo breast conservation therapy after receiving neoadjuvant endocrine therapy. And that may provide long-term disease control for patients who are poor surgical candidates. So if someone has a lot of comorbidities and can't undergo a resection, or if they happen to be quite elderly, or if they don't want surgery, it may be a way to just sort of keep their disease stable. There are no studies, basically, though, comparing it to neoadjuvant chemo or comparing endocrine in the neoadjuvant or the adjuvant setting, and no one knows the optimum duration of treatment. They did find, however, in some of the very, very small and sparse studies that the aromatase inhibitors, such as Arimidex, have better rates of breast conservation therapy than tamoxifen when you give it in the neoadjuvant setting. So briefly, just to go over quickly, the surgical management of advanced breast cancer is exactly the same as it was for early stage breast cancer that Dr. Muir reviewed a couple of weeks ago. But your options are partial mastectomy with sentinel lymph node biopsy, partial mastectomy with axillary lymph node dissection, total mastectomy with sentinel lymph node, modified radical or radical mastectomy. So in a partial mastectomy, we know that the survival rates are equivalent to mastectomy when accompanied with radiation therapy. This is also known as breast conservation therapy, or BCT. However, you must be able to achieve negative margins, the patient must be eligible and willing to undergo radiation therapy, and you must be able to detect local recurrence in order to undergo breast conservation therapy. Some contraindications that we all probably know is multicentric disease. You can't have multiple lumpectomies on the same breast. Diffuse calcification throughout the whole breast, pregnancy because you can't receive radiation, prior radiation exposure, persistent positive margins, and some argue that the presence of connective tissue diseases such as scleroderma or lupus preclude you from receiving radiation. Modified radical mastectomy, as we talked about earlier, is removal of all the breast tissue and the axillary contents in block. You have to design your incision to include your biopsy site, and if you're not going to reconstruct, you need to be sure to remove enough skin for a flat chest closure. So the radical mastectomy that I alluded to before, developed by Halsted in the 1890s, includes removal of all breast tissue, the pectoralis major and pectoralis minor, level 1, 2, and 3 lymph nodes, and your axillary and supraclavicular nodes. It remains a key component to the management of selective T3, T4 tumors and N2, N3 disease. However, some question it may have a role in achieving local control in patients with stage 4 tumors. It's likely that the Halsted radical mastectomy is going to continue to go by the wayside as we get better and better adjuvant and neoadjuvant therapies, but some argue that for stage 4 disease it still may play a role. So when you talk about stage 4 breast cancer, which basically means metastatic breast cancer, and it used to be a relatively uncommon thing because the patients succumbed relatively quickly. However, nowadays as our chemotherapy, our endocrine therapy, our screening, our awareness, and everything continues to improve, we're going to have more and more patients with stage 4 disease that are alive and stable, meaning that their disease doesn't get worse and doesn't get better. And so some have begun to argue that we need to resect the primary tumor. Historically, mastectomy has not been shown to improve survival after you have developed metastases. Resection has often been used and reserved only for palliation. But there are some recent retrospective reviews that have shown improved survival and metastatic disease-free survival, so meaning their metastatic disease does not increase when you resect the primary tumor. However, in order for this to be effective, you need to, of course, have negative margins, and they found the best results in those patients who only have bone mets. So at WashU in the in the early 2000s, reviewed data from the late 1980s up into 2003 from the SEER database, and they compared overall survival in stage 4 patients between those that had surgery and those that did not. They adjusted for all confounders: age, race, marital status, tumor size, tumor grade, hormone receptor status, whether they received radiation, and their year of diagnosis, because things changed quite a bit in that 20 years. The median survival, they found, was longer for women who had had surgery than for those who had not. This was 36 versus 21 months. They concluded that the risk of dying was 37% higher in those who did not undergo surgery. Their study, however, did not account for the causal relationship. They just merely looked at the data from the database or the treatment decisions, though they have no idea what went on between the surgeon and the patient, how they decided to operate, and who was even offered surgery versus who was not. But they did argue that they're starting to show some relationship between resecting the primary tumor. In 2008, Rao looked at the single institution retrospective review from MD Anderson. They love to look at their own data. What they showed is that resection of the primary tumor and axillary nodes improves metastatic progression-free survival. So it's a lot of words basically to say that the metastatic disease doesn't get any worse. And they found the best results when you operated greater than 3 months after diagnosis, which makes sense because most people are getting a little bit of chemotherapy by that point. It also had the best results in patients with one site of metastasis, negative margins, and the Caucasian race. So this is not anything new, but they found that in patients who are not Caucasian, they often underwent only a palliative resection and were not getting multidisciplinary therapy, and so resecting the primary had no impact on their survival. So overall, surgical resection can help restore the patient's immune system, improve their nutritional status, decrease seeding of metastasis, and increase the efficacy of adjuvant treatment. By lowering the tumor burden, you can limit the development of chemo-resistant cell lines, and some postulate that resection of the primary tumor causes a surge of angiogenesis in the distant metastases, which then can increase chemosensitivity. Lastly, the primary tumor may influence metastatic disease progression through the release of immunosuppressive factors. So therefore, immunocompetence is restored after you resect the primary tumor and sever the dependent relationship between the primary and the metastatic disease. So some also argue that you need to resect the site of metastasis. So for breast cancer, as we all know, it goes first to the bone, then to the lungs, then to the brain, and lastly to the liver. Those patients who have only bone mets have the best prognosis, and they can even undergo chemotherapy or endocrine therapy that helps prevent pain and pathologic fractures. There's a very, very small study that showed when they resected solitary sternal mets, they improved the quality of life for these patients and potentially increased survival. But you have to, of course, realize these are a small subgroup of patients who could tolerate such an operation. They also argue that you can resect isolated pulmonary or hepatic mets if the patient's a good operative candidate, and it may increase disease-free survival. Brain mets are the same. If the patient has isolated brain mets, they're a good operative candidate. They could possibly be treated with whole brain radiation plus or minus resection. This is my last slide for our celebrity breast cancer. It's the sad one, too. Yes, Elizabeth Edwards. She was diagnosed at age 55. He knows them all. Diagnosed at age 55, and she died recently at age 61. The next is a local celebrity. If anybody watched the news last week, it was everywhere. This is Karen Martinez from Fox News here in San Antonio, and she died last week from stage 4 breast cancer. She was 37 years old. So as we heard about a couple of weeks ago, and I mentioned a couple of times, there is endocrine therapy that can be used for advanced breast cancer. So anyone that has an ER/PR positive tumor, so estrogen receptor, progesterone receptor positive tumor, is going to receive endocrine therapy. If you're premenopausal, it'll be tamoxifen, which reduces your recurrence risk by almost 50% and reduces your mortality by almost 33%. If you're postmenopausal, it's going to be the aromatase inhibitor, such as Arimidex, which also shows an improvement in disease-free survival, time to recurrence, and 42% reduction in contralateral breast cancer. We talk about HER2-positive breast cancer is another subset, and most of these are usually considered to be advanced because they're quite aggressive. And the adjuvant therapy that goes along with the HER2-positive is, of course, Herceptin for 1 year after they've completed all other treatment. Herceptin is a human monoclonal antibody to the HER2 receptor that's expressed in HER2-positive breast cancer. It's given weekly for 1 year after chemotherapy. It's been shown to improve your disease-free survival from 67 to 85.3%, improves 3-year survival from 91 to 94%, and also been shown to decrease recurrence. The problem with Herceptin is it's toxic to cardiac myocytes, and so you need to monitor the cardiac function while people are on therapy. And then last week also, we heard about Kadcyla, which is basically Herceptin, so you see the trastuzumab name here, maybe. And they linked it to amantine, which is a chemotherapy agent, and basically what it does is it allows targeted delivery of a highly potent chemo agent. So the Herceptin allows it to go directly to the HER2-positive cells. And so not only do they get the Herceptin, but they get blasted by a very potent chemo agent. And it allows those cells, allows us to kill off those cells. It's only been approved for stage 4 disease, so those with metastatic disease. And the very, very, very new and limited data shows that it increased median progression-free survival. So meaning progression-free survival means your disease gets no worse, no better by 3.2 months, and that's the median. So most importantly, I think, is it's an interesting way to start treating breast cancer. It's already being used in CML and in Hodgkin's, where you can couple these hormone receptors so you know that the drug is going to get where it needs to go, thereby bypassing all of your normal cells that you don't want to be killed off. So lastly, I'm going to talk a little bit about inflammatory breast cancer, which is usually always lumped into the category of advanced breast cancer because it's even more aggressive than HER2-positive breast cancer. And the incidence is about 1 to 6% here in the United States. The AJCC classification is diffuse erythema and edema, the peau d'orange, as you guys can see here quite easily in the pictures. And it's often without an underlying mass. So you notice an abnormality in the breast, but you can't feel a discrete mass. And the majority of the entire breast is involved. Most commonly infects African Americans, and the mean age at diagnosis is 58 years old. MD Anderson looked at their patient experience from 1974 to 2005, and all those patients that were seen there diagnosed with inflammatory breast cancer, their median survival was only 4 years, and the median time to recurrence is only 2 years. Inflammatory breast cancer can often be confused with locally advanced breast cancer, but there is a big difference. Inflammatory breast cancer invades the lymphatics of the dermis. That's why you get all these skin changes. It can arise within 3 months. It's often not associated with a palpable mass. The incidence of involved axillary nodes, so essentially that the disease has spread local regionally, is 72%, and the incidence of distant metastases at the time of diagnosis is 20%. And most of these, unfortunately, are ER receptor negative, which means that you don't have your endocrine therapy to use as adjuvant treatment. So if you can't feel it, how do you diagnose it? Mammogram or ultrasound is usually your first line. Nowadays, our mammograms are getting better. Because there's no discrete mass, you have to be able to pick up on the architectural distortion, which can be subtle, but our mammograms are getting better. The MRI is the most sensitive. This is an example of an MRI you can see here. And then you, of course, want to do your PET or a CT scan for staging. If you're going to diagnose somebody in the office, you don't need to take them to the OR for an incisional biopsy. You just do a skin punch biopsy or core biopsy right there in the office. FNAs do not work, mostly because of the dermal lymphatic tumor emboli. So the skin is all blocked by tumor emboli, and if you do an FNA, you're not going to get a reliable sample. So what do we do to treat inflammatory breast cancer? It is, of course, always a multidisciplinary approach. Surgery is never the first-line treatment. They always get neoadjuvant chemotherapy, followed by surgery, maybe radiation, plus or minus Herceptin if they're HER2 positive. The chemotherapy is the only thing known to improve disease-free survival and overall survival. You can see major responses in 70 to 80% of the patients. Surgery becomes controversial because local regional recurrence is only about 20% after neoadjuvant chemotherapy. And there is a little bit of a survival difference, but only if they've responded well to the neoadjuvant chemotherapy first. So 48 versus 37% who didn't undergo surgery. Some argue that surgery removes your chemo-resistant disease, and then you also are able to get an accurate assessment of the pathologic response to the chemotherapy. So 2/3 of patients who have a complete clinical response, so their breast goes from big, beefy, red, swollen, puty orange look to essentially a normal-looking breast. 2/3 of those patients will also have a complete pathologic response. So what is the surgical management? Well, it's not the initial therapy, as I mentioned. And if you have a patient that comes to you after neoadjuvant chemotherapy or before and they have clinical evidence, so all those skin changes of inflammatory breast cancer, it's considered inoperable disease. You can only perform the modified radical mastectomy on those patients whose skin inflammation has resolved after neoadjuvant chemotherapy. If you don't, it's shown poor survival and local control if the patient is a non-responder. So if they get chemotherapy but they still have skin changes, their local recurrence risk is 89%. Versus 33% of those who do have a response. Some have documented, this is Monica Morrow up in Sloan Kettering, she saw chest wall recurrence within the second post-op week after resecting inflammatory breast cancer. If you still have disease present, then you need to proceed with radiation. So if they do have a good response and you are going to perform surgery, it's a modified radical mastectomy approximately 2 to 3 weeks after completion of neoadjuvant chemotherapy. You need to make sure you can get negative margins because positive margins are associated with a very poor survival. So 47 versus 0% at 3 years. You don't do a sentinel lymph node biopsy, you automatically clear the axilla because the tumor obstructs the lymphatics and so it's unreliable. And remember, you had such a high incidence, 70% of axillary disease, so just do the axillary dissection. They do not qualify for a skin-sparing mastectomy, obviously, with all the skin changes that has to be resected with it. And you need to delay reconstruction until you complete all therapy because it has such a high risk of recurrence. In summary, as breast cancer survival continues to increase and our screening gets better, more women will be living with the disease. Management of locally advanced and inflammatory breast cancer begins nowadays with neoadjuvant chemotherapy. There further studies may reveal a role for neoadjuvant endocrine therapy as opposed to or perhaps in conjunction with neoadjuvant chemotherapy. And sentinel lymph node biopsy at this time, until we see better data, I think provides the most accurate results prior to neoadjuvant chemotherapy. And resection of the primary tumor may improve survival in certain subgroups to stage 4 disease, which is good for business. And I think as our treatments get better that we may see these patients as they qualify for resection after they've received their chemotherapy. I thank you for your attention, and I'll take any questions. Dr. Toy's not here.
What about BRCA1 and BRCA2? Is there a higher incidence of that in people who present with advanced?
Not really. It's still a small percentage of patients, and if someone is young and they fit the criteria for genetic testing, so if they're under the age of 40 and they present with advanced disease, they're going to get tested. I think we're going to see the trend of patients know, and the awareness is so much better, so they know it's in their family and they're being seen sort of prophylactically first off. But if you come with advanced disease and you're young, you're going to get tested.
Dr. Cruz.
What can I say? Simply said, another wonderful presentation. You really covered it well. I'd just like to point out a few things, and just for our own edification, and that you cited B18 and B27. We were one of the top contributors to that. And apropos of that, we found out that sentinel lymph node biopsy after neoadjuvant was possible. Mm-hmm. You pointed out 94.7% for NSABP. That is our average. And our pathologists here really became well-versed in examining specimens after neoadjuvant. So we depended on neoadjuvant therapy and the interpretation of the pathologist. But as you said, the overall survival may not have changed with neoadjuvant, but it certainly downstaged the disease so that we could do more breast conservation therapy. You mentioned something about hormonal treatment for advanced CA. That's well accepted in Europe, especially in Great Britain, as you probably know. But in the United States, the surgeons and the patients tend to be a little bit more impatient. They cannot wait 6-8 months for the tumor to shrink with TKIs, with AIs. And so we use it here, but not as much as in Europe. And then you brought up something that the late Dr. Oz was always saying. It's good to take out the bulk of the tumor because you increase the growth fraction of the tumor system and therefore be more sensitive to chemotherapy. That is really something that we need to keep in mind. And then, of course, we have the Trojan horses now, the TDM1. I have a hard time remembering the commercial name. It's almost like Godzilla or something.
Kadcyla is how
But again, I enjoyed it, and I congratulate you for this excellent review. Thank you.
Dr. Stewart.
So Meeghan has a great content, great slides, great delivery. I think all of the residents' talks have been excellent. Although I'll just say specifically for my breast topic, if you were to take your talk and Dr. Muir's previous talk on breast cancer, probably two of the best talks on breast cancer. I would recommend that, for example, for people who are taking the recertification exam. All they really need to do probably is listen to those two talks. And they are recorded, by the way. These are recorded, but super talk. I'm not going to ask any question, but while I'm on the rare time of bragging, I will say that at this past weekend, South Texas chapter, Heather, Sal, and Travis all presented their research. Heather won the best presentation at the resident paper competition. Joga and Luke competed admirably in the resident Jeopardy contest and the surgery skills contest, and although they didn't win either of those, they did super great. So congratulations to all the residents, really.
And you only misspelled Halstead once.
Oh, I did? Okay, good.
Dr. Pruitt were here, he would be proud. Just ED. Dr. Dent? No? All right, thank you very much, Meeghan. All right, who's up? Dr. Medina?